Well, for those of you that waited, thank you, and appreciate you joining me this afternoon. I have a conference with a different slant today. We're going to look at skull imaging, and as part of the reason I find neuroradiology so interesting is it's really not just about the brain and the spinal cord. Neuroradiology encompasses all of the containers, so spine, skull are part of areas of expertise, and as you probably know, neck imaging, including ENT imaging, is all part of neuroradiology. So we'll get started with this first case. So on this MR scan, I want you to just focus on the circled area where you see this area of signal abnormality in the region of the skin and the skull. And as you consider that, the first thing I want you to learn from this conference is don't ever try to offer a firm diagnosis on things involving the skull unless you have a CT scan. Now, I may make an exception to that in a patient where I know that there's an underlying cancer like breast cancer or myeloma, and I see a skull lesion. But my experience has been that you can get pretty far afield if you think you know what the CT scan is going to look like. And so it's not a very high bar to get over. So I want you to consider getting a CT scan whenever you consider the finding that you see on MR. So now I'm going to show you the CT scan. And I'm going to ask you what you think this represents. So here are your choices: fibrous dysplasia, and enchondroma, osteoma, intraosseous meningioma, and intradiploic epidermoid. Okay, so we have some takers for osteoma and intradiploic epidermoid. So let's take a look at that. And let's analyze these. So fibrous dysplasia, is classically described as a ground glass appearance in this skull. And what I'm trying to show you on these images, which include this bone image, is that this lesion has pretty much the same attenuation as cortical bone. So the fact that it projects outside of the skull tells you that the patient probably was able to feel this and should feel hard and unmovable. And this is what's called an osteoma of bone. So if we go back to the MR scan, it really has very little to speak of, right? And you can see this area of signal dropout here. There's a little bit of signal dropout here. Now, this high signal intensity in the skin could be a susceptibility artifact because we're at a bone interface. And then you noticed on the enhanced scan, there's no enhancement associated with it. So this is a no follow-up needed benign lesion of the skull. It's called an osteoma. These can be quite large at times, but if you see homogeneous cortical bone attenuation in the lesion, then you're going to favor osteoma of bone. Now let's look at this patient. This here you can see there's an area of thickening of the skull. This is post-contrast, and there's a little bit of enhancement on the surface of the brain here. It looks like the skin is elevated, and there's a lump there that, again, the patient probably can feel. This is what it looks like on the T2 weighted scan. This is what it looks like on the ADC map. And here we are on, I think this is diffusion. So can you offer diagnosis here? And I'm going to show you one other piece of information here. This is the CT scan from 2020. This is the CT scan from 2021. So Here's our next poll. Do you think this is fibrous dysplasia, metastatic disease, lymphoma, intraosseous meningioma, intradiploic epidermoid, or an osteogenic sarcoma? So we have a couple takers for fibrous dysplasia. So seems like that seems to be the going thought. And let me just show you how you should approach this lesion. The first thing I want you to notice is the vertical lines that you see here. They're a little faint, and I realize you're not looking at this carefully on a PACS monitor, but this kind of people describe as hair on end look should suggest a malignancy. Usually this is a periosteal reaction. It's usually associated with osteogenic sarcoma, but from the time interval I'm showing you here that it's unlikely this is an osteogenic sarcoma that grew just a little bit over the course of a year. The enhancement of the dura and the extra axial space here is another feature that you would not expect to see with fibrous dysplasia. Fibrous dysplasia is a benign dysplasia of the bone, and it shouldn't really have any invasion or reaction in the meninges. Now, the fact that it's low signal intensity on the T2 weighted imaging is simply an indication that this is an area of sclerotic bone, which of course has a short T2 relaxation time. So we have this focal area of sclerosis. We don't have a big soft tissue mass that's enhancing. We know from the fact that it's not bright on the diffusion scan that this is unlikely to be a intradiploic epidermoid. The findings in this case, even though you probably have not seen one of these in your daily practice, this is an intraosseous meningioma. And you just have to know that's how they look, because meningiomas, the way we usually think of them is an extraaxial soft tissue mass, occasionally intraventricular, but usually enhancing quite vigorously, where this doesn't seem to enhance that much because, again, you're really looking at sclerotic bone. So this was excised, and that's what the pathology was on this. So again, you want to consider that possibility of intraosseous meningioma. Now, I know why you were thinking fibrous dysplasia, because I just told you that you see a ground glass appearance, and I agree. This has kind of a ground glass appearance to it. But again, I'm trying to show you all the imaging, and so this works the same way. When you see the CT scan, in this case, the CT was done first, in trying to characterize this lesion by going to the MR scan, it gives you a chance to make those additional observations that should lead you away from fibrous dysplasia. All right, now we have another MR scan. This is case 3, and you can see that here's the normal fat in the diploic space. Here is some expanded bone that has low signal intensity on the T1 weighted imaging. It stays pretty dark on the T2 weighted imaging, and maybe there's a little bit of enhancement, kind of ill-defined at the periphery of it and maybe in through some of the interstices of it. So what do you want to see next? Of course, now you're going to say, well, I'd really like to see the CT scan. And so here's the CT scan. Here it is on the bone window or bone filtered image. Here's a different level, again, showing you the same lesion. So let's see what you think of this one. So do you think this is fibrous dysplasia, an intraosseous meningioma, lymphoma, or metastatic disease? Doesn't hurt to answer. It's all anonymous. You'll learn by making mistakes while you're in training. I still remember cases I missed when I was a resident. It somehow gets seared into your memory. Well, so I think this is a very fair assessment, and I think that I understand why the answers are there, but I think we're in the right family of disease, fibrous dysplasia and intraosseous meningioma. Now, this proved to be fibrous dysplasia. Now, the features that make you think about fibrous dysplasia is that you notice that it has a very smooth border, unlike that other case I showed you that had that kind of hair on end appearance. So this has a more benign appearance. There are some areas where you don't see the ground glass appearance. So fibrous dysplasia is frequently inhomogeneous. Fibrous dysplasia also has this unusual feature of enhancing, and in my opinion, looks a lot like metastatic disease, because you'll notice that there's also this loss of the fatty marrow in that space. And here you see on the T2 weighted scan a few of the cysts. So again, this is a close call. There are going to be cases where maybe you're not sure. But again, in terms of frequency of occurrence, fibrous dysplasia is much more common than intraosseous meningioma. It's frequently seen in younger patients, and I think those features may help you in making the distinction. But again, intraosseous meningioma usually should be sclerotic, will grow over time, and may have some more aggressive features on the bone imaging. Fibrous dysplasia is usually complex, enhances more than does the intraosseous meningioma, and has this, again, if you look at it here, there's more ground glass appearance. All right, let's look at this case. So here we have a finding on the right side. You can see the normal, this is a T1 weighted scan, and in the diploic space, there's usually some fatty marrow, which gives you this high signal intensity. Again, you see the high signal intensity here, high signal intensity here, although it's a little odd looking on the right side. There might be a little more enhancement over here if you look at this side and this side. This is what it looks on the diffusion scan. This is what it looks like on the FLAIR scan. A little bit of signal here, but you really don't see much in the way of abnormal signal here on the diffusion weighted imaging. This is what it looks like on the CT scan, both in axial and coronal view. So let's see. It's our fourth case. And do you think this is fibrous dysplasia, intraosseous meningioma, Paget's disease, metastatic disease, or lymphoma? Okay. So this one is happy to see 3 people felt it was Paget's, and this is Paget's disease. Paget's disease, as you know, can have a varied appearance, often expands the bone. I don't think there's much in the way of expansion. The feature that I want you to notice about this case, and the argument against metastatic disease, is usually when you have metastatic disease, there's displacement of the fatty marrow by the tumor elements, which will not have the property of T1 shortening. So Paget's disease, for some reason, will retain some of the fatty marrow, which is what you see in these locations, often has these kind of cystic destructive lesions. And the other thing I want you to notice is you don't see much on the diffusion scan. Metastatic disease, usually, if you look for it, you'll see some abnormality in the bone, in the diploic space on diffusion weighted imaging, presumably from the dense cell packing in the malignancy in the bone. So these 2 reasons why we would vote against metastatic disease are the preservation of the marrow largely in that region and the absence of any findings on the diffusion weighted scan. Certainly lymphoma would show high signal intensity on the diffusion weighted scan, as would an intraosseous meningioma. And we're not thinking of an intraosseous, intradiploic epidermoid, and lymphoma would be bright. And with intraosseous meningioma, we wouldn't expect to see these cystic areas. So this is a case of Paget's disease. Now, this is a different patient, of course, but a more exaggerated appearance of Paget's disease. Now you see the widening of the space and this kind of odd mix of sclerotic bone and lytic areas. But again, on MR scan, you would expect there to be some preservation of the marrow in this case. And this is, I think, our last case. I want to show you this lesion. Here you can see there's an abnormality, interruption. Here's the dysploic space marrow. And you can see this, some people will call these beveled edges. There's a lesion sitting in here. This is what it looks like on the diffusion weighted imaging. This is what it looks like on the CT scan. Notice that it has like a sclerotic margin around it. So do you think this is a case of fibrous dysplasia, intraosseous meningioma, intradiploic epidermoid, metastatic disease, or lymphoma? Okay, very good. So, favored intradiploic epidermoid, and that is the correct answer. Why intradiploic epidermoid and not lymphoma? Lymphoma will have restricted diffusion frequently. Again, this is a dense cell packing lesion, just like medulloblastoma. And some meningiomas, they have restricted diffusion. But the argument against lymphoma is the sclerotic margin to it, which gives you the feeling that this is something that's been there for a while and is remodeling bone, as does this kind of beveled edge you see on the sagittal view. So when we think of something that is, in a sense, a benign lesion, and again, when we talk about neuroimaging, and particularly in talking to the skull, there is no benign disease, as in nothing to worry about, because even benign tumors can cause quite a bit of disability or mortality if they get large enough. So benign and malignancy there's a histologic meaning to them, and then there's a more sort of a broader sense. We use benign to imply that it doesn't have any significance to the patient. So intradiploic epidermoid histologically is normal, and that would explain the sclerotic margin to it and this little preservation of the shelf of bone here. So these are, again, slowly growing rests, and so this particular one, they might excise if this is a young patient, just because they probably will grow as time goes on. But typical imaging features, again, of smooth remodeling of bone and restricted diffusion, or not so much restricted, because you see it's not that dark on the ADC map, but high signal intensity on the diffusion weighted imaging is the hallmark. Both of the intraosseous epidermoids and, of course, the epidermoids that occur in the CP angle cistern and paracellular region that are separate from the bone, they all have this property of high signal intensity on diffusion. All right. So remember, for those of you who missed it at the beginning, the number one rule I have for skull lesions: don't read the MR. I mean, you can read it, but you want to say in the end you'll offer a firm differential when you see the CT, because some lesions, particularly fibrous dysplasia, can look quite malignant on the MR scan, but proves to be a benign lesion. And I may have told some of you this story, but early in my career, I had a patient with breast cancer who after she came out of the scanner, it was one of the night cases, and I happened to be reading her scan, and I encountered her, and I was asking her about symptoms and so on, and I indicated that we saw something on her scan, and she said to me, "Oh, I wonder if you're seeing my fibrous dysplasia," because she, of course, had known about it for years, what it proved to be. So don't read the MR without the CT, but when you have them together, you'd want to use the findings from both studies to form a coherent diagnosis that best matches the findings. If you're not sure, and there are going to be cases where you're not sure, some lesions, I didn't show you hemangiomas of bone, they can be quite confounding, and so I want you to use all the information at your disposal and reach a coherent diagnosis. Remember that some skull lesions, lytic lesions, can be biopsied with the needle that don't necessarily require surgery, depending on the skill and opportunities for trajectory for the interventionalists. So thanks very much for joining me this evening, and I hope you got something out of it. I noticed that as the few cases we showed went on, that I think the answers got better. So hopefully you learned something from that. Any questions?
Oh, thank you so much for the lecture. I just have one question.
Yes.
Would you mind clarifying just one more time the key difference between the intraosseous meningioma versus fibrous dysplasia? Is it more the borders of the lesions, not so much the ground glass or the enhancement pattern?
I think it's all of those. So you want to look at the quality of the margins. Does it show periosteal reaction? Is it smooth? You want to look at the overall look of the lesion. Intraosseous meningiomas tend to be more homogeneously sclerotic, whereas fibrous dysplasia often has this mixed sclerotic lytic quality. And then, yes, as you indicated, finally, that the intraosseous meningiomas tend not to show enhancement centrally, whereas fibrous dysplasia, it's a more loosely aggregated lesion, tends to have areas of enhancement within it. But again, there will be cases where, and honestly, that case I showed you of the intraosseous meningioma had initially been reported as fibrous dysplasia at an outside hospital. So sometimes you need a little bit of time to go by, and I think the MR scan to be able to make the distinction. So I don't pretend like this is easy in all cases, but you want to look for these imaging features and then sort of slant your differential to match the findings.